I would like to invite Dr. Sbai. Mo, is that how I say your last name? I keep asking every time, and I keep not saying properly.
You got it right. You got it right.
Good. Dr. Sbai is a great part of our institution and comes from a totally different perspective that we as surgeons and in the surgical community don't necessarily think as much about. And that's why it's so important to have him speak and share a little bit about his work with us today. Dr. Sbai has been in the neurorehab area of expertise, and actually before the University of Utah worked in the pharmaceutical industry and helping develop neuro-related medications after his PhD and postdoc, which I believe he did in France, if I recall correctly. And so he's had a variety of different experiences that I think is useful to recognize and be a part of. And the other part of why it would be useful to hear about his work is that so often we focus on the technical component of surgical care delivery, but that doesn't necessarily mean that patient outcomes are any different, because a lot of that has to do with how they recover and the right systems that they need to have in place to recover. So we often stop like at a certain point in our mental thought processes, and I'm hoping that Mo will push us beyond that inherent barrier. Great. And then Cody is one of our medical students. Hi, Cody. I just finished introducing Dr. Sbai, but I'm sure he'll talk a little bit more about his work in a few minutes. And Cody's one of our medical students is joining on to hear about what kind of work we're doing.
Cool.
All right, go ahead. Take it away, Dr. Sbai.
Thanks, Sudha. It's great to be with you guys here. So like Sudha mentioned, I'm fairly new with this group, and today I'm going to bring you something that is totally different from the regular topics that we see in this setting. I wish I was able to bring you some surgery-related stuff, because this is actually related to neurosurgery. As you will see in Morocco, there is a fairly good neurosurgery facilities across the country, but it's the aftermath, whether it's neurorehab or home care, that is lacking. So this project, like Sudha, my background is in neuroscience. This project was actually inspired by the passing of my older brother, who suffered a severe traumatic brain injury in a car accident in Morocco. That was in 2007. And the process of taking care of him, both in Morocco and here in the US, really opened my eyes on the tragic lack of neurorehabilitation services in that part of the world. So soon after his death in 2009, I decided to carry on this very ambitious project to try to bring this medical specialty to Morocco. And then I started a nonprofit called Zahra Charity, named after my mom, who helped me a lot taking care of him when he was with me here in the US. And took many years to get to the point where we had enough resources to actually start the neurorehab clinic that I'm going to discuss with you today. Just a couple of numbers to guide you, or to basically make you aware of what's going on in Morocco. Morocco has the size of the state of California, roughly, with about 40 million people, and estimated to have at least 1.2 million people dealing with neurological disabilities, knowing that they don't have access to adequate neurorehabilitation. And also knowing that there is a strong stigma, prejudice, and discrimination against these people. And sometimes, as I experienced with my late brother, even within the families. the variety of statistics that I was able to gather, again, because of the nature of the developing economy and developing countries of Morocco, there is no solid data, but this is the best that I could come up with. But it is estimated to have about 25,000 cerebral palsy cases every year. And there are about 40,000 traumatic brain injury and spinal cord injury every year. And there are about 10 to 15,000 stroke cases, new stroke cases every year. The project that I come up with, which is starting neurorehabilitation services in Morocco, received a lot of support. So I want to start by acknowledging these entities and institutions before I dig into the presentation. On top of them, obviously, as you can imagine, University of Utah, to implement or to bring rehabilitation services for the first time in any place. It doesn't happen with money. Obviously, money help, equipment help, but you have to have the proper training of the people who are going to deliver those services. So we recognize that was a critical things to have before we even start the project. And again, the University of Utah School of Medicine and Hospital played a huge role there. And I'm going to discuss this more. Rotary International foundations help us a lot with the grant that's actually paid for those training. Sorensen Legacy Foundations help us with funding to support the daily operation. LDS Charities Foundations also helped with the global grant that we got from the Rotary, but also to purchase equipment. IHC Healthcare and other US medical institutions also participate in the training. And then last but not least, Global Relief, which is a large NGO based also in Salt Lake City. They specialize in refurbishing medical equipment. They help us purchase used medical equipment at a very, very steep discount. So the clinic that I'm going to talk to you about, we named after my late brother, Moulay Ali. So it's Moulay Ali Institute for Rehabilitation. We decided from the beginning that it's going to be focused on the American model for neurorehabilitations. And the staff, like I said, has to be trained. And we start that that process in 2014. Just a quick background about this clinic and how it's operating. As Sudha mentioned, my focus as far as my research and my work here at the College of Health is how to apply brain plasticity in developing neurorehabilitation tools and therapies. And that's the philosophy that we try to build on at the MAIR clinic in Marrakesh City, Morocco. We believe that human brain, as you probably know, can change both structurally and functionally. So it can adapt, heal itself, and restore lost functions in so many cases. And we really, from 2014, we really tried to instill this idea and this concept in the head of the therapist. And I have to say, I'm grateful to see that they have taken it into their heart, and they're doing a really good job with it. The MAIR Clinic is a very small facility. We are renting a small building, about 2,800 square feet. And again, like I said, it's located in Marrakesh City, which is one of the largest city in Morocco. And it's very convenient as far as the locations, close to public transportation. But like you will see later, we are in the process of trying to expand this facility into a much bigger building, about 20,000 square feet. The work at the clinic starts like we know it here, 9 to 6 p.m., Monday to Friday, and then half a day on Saturdays. We are treating right now about 78 patients with the growing list, waiting list, because even if we don't advertise, a lot of patients are coming from all over the country, actually. They are treating the patient, the therapists are treating only outpatients at the pace of about 30 to 35 patients a day. Total number of patients treated so far exceed 350, and total number of people affected by the services exceed 2,000. In the beginning of the MAIR operations, none of the patients were paying. Obviously, this is a not-for-profit operation, but because of the results and because of the positive impact that MAIR clinic services start having on the patients, we started seeing more financially capable people coming into the clinic, the one that have medical insurance and so forth. So approximately about 40% of the patients are paying something for therapy. The clinic is still not self-sustaining, so they are still running into the red from the beginning. But we anticipate financial self-sustainability will be achieved if we have anywhere between 65 to 70% of the patient being paying. The current staff is about 8 therapists strong. Like I said, all of them were trained on the American model of rural rehab. Some of them actually came to Utah, like you will see later. We did so far 2 training between 2014 and 2019. And like I said, the funds came from Neurorehabilitation International. And like Sudha and Catherine knows, we're in the process of putting a third training, which we hope will end by establishing a formal neurorehab curriculum in Morocco, which would be the first of its kind. We received the grant for $200,000. Half of that will be earmarked for this curriculum building, and the other half for medical equipment that we will need in the MAIR expansion project that I'm going to share with you today. Briefly, this is the small building that we are in right now. We have to do some remodeling, so this is construction work. This is what the clinic looks like. Over here, it's the front desk and the little space where we meet, or where the staff meet, actually. This is the main hall of the room, where we have gait training and some other balance therapy, vision therapy. A lot of things going on in this little hall. Over here, the corner, right there, this is the room. We call it pediatric therapy room, and this is a general therapy room where we do stretching, electrical functional stimulations, and some other stuff. So the training that I mentioned, I just want to share with you some pictures. This is the first team that came to Utah. 3 therapists came to Utah, again, funded by Rotary International. They were trained here at the U, but also at other facilities across the valley, like IHC, NeuroWorks, and some other facilities. So you can see pictures of different staff members from the US. We don't have HEPA rules in Morocco. So the first, when they come first into the clinic, they are allowed to treat the patients, interact with them, and do whatever they want. You probably recognize this gentleman, Dr. Mike Green. He's a pediatric neurologist and neurorehab guy at the Children's Hospital, the Primary Children's Hospital, and Neurorehab Hospital. Like I said, when you start a project like this in a place where none of those services exist, obviously, like I said, you have to have medical training of the people who are going to deliver those services, but you also have to have equipment. And when I decided to focus my career on rehabilitation many years ago, one of the equipment that I was certified to use is called locomotor training. I got that training at the University of Louisville, Kentucky. And the machine that allowed this therapy protocol cost about $90,000 here in the US. So we couldn't afford it. And I decided to take some ideas about the plan and the design of the machine. And I went back to Morocco with the help of a welder, and we were and $3,000. We were able to basically rebuild the same machine. It's not automated, it's not high tech, but it does the job. And I want to show you these quick videos to show you how this protocol actually works. So you can see there are two therapists on both sides of the patients, and the third therapist is holding the pelvis, allowing the movements in a very specific way. The two therapists on the side, they are basically moving the legs, trying to mimic the locomotions, while they are delivering very specific sensory input around the knee and around the ankle. This has been shown in the UCLA research lab in the 90s, using cats as animal models to be tremendous for reestablishing walking abilities after severe spinal cord injuries. So again, thanks to the training by the U.S. medical professionals, the med therapists start producing really great results for their patients fairly quickly, in about 6 months. And like I said, we started having a lot of interest from the local patient populations and medical communities. And here I want to share with you some success story very briefly. This is a Guillain-Barré case. His name is Sulaiman. So he was treated in the hospital, in public hospital. You know, with Guillain-Barré, it's a conditions that actually caused by the some kind of infections most of the time, and it's it behaves like an autoimmune disease where the immune system of the patients start attacking the nerve cells in the spinal cord. Once the progression of the disease has been stopped with the medications, rehab is very important actually to recover the loss of functions. And in this case, this little boy, he couldn't bear weight, and he couldn't obviously walk or maintain his balance. So he's only moving thanks to his mom holding his hand and the body weight support that is actually supporting him. So you can see he can absolutely not able to do anything with his legs. And then here he is 7 months later, therapy, running around the clinic. He became a healthy boy. We discharged him, and a couple of years later, he went to school, and he's perfectly normal boy. This is another little guy who suffered traumatic brain injury in a traffic accident. He was hit by a fast-moving motorbike. His name is Ala. When he came to the clinic, he was in a vegetative state, and he can only respond to strong stimuli like pain. And that's what I was trying to do here. I want to see how much pain he can respond to. And then when you can see when I really punched him, he really responded in a very unhappy way. So to me, that was the very, very good sign that his prognosis was actually pretty good. And sure enough, we also prescribed some medications that they were not known in Morocco. Among them was amantadine. You probably heard about the medications, but that in combinations with the really comprehensive neurorehab protocol that we put together, including speech, because he was not able to communicate in the beginning. The results are here. So this is one of the first therapy sessions at the clinic. You can see, again, unable to bear weight, unable to walk. That's, by the way, his father. And we recognize that family involvement is extremely important, and his father is an extremely good job. This is later on in the therapy where he started recuperating some gait abilities as well as some balance. And this is in the middle of the process of therapy where he starts communicating a little bit, and then using his upper extremities. And again, this is some vision therapy, but also some communication and speech therapy. And then here he is, almost rehabilitated completely. He loved the treadmill. Once he was able to walk, one of his favorite exercise after therapy is to walk on a treadmill. Ala now he's about 15 years old. He went back to school, very successful, very healthy young boy. Speech therapy, we found he used to love singing before his injury, and we found that music therapy was a pretty good tool to address his speech deficit, and sure enough, it really helped very well. So he is singing. So that was his favorite song. Last but not least, this little girl over here, one of my favorite patients. Her name is Ghalia. The photo taken here is in the clinic south of the valley in Sandy called Neuroworks. She experienced the same scenario that my late brother went through, meaning that after his injury, which we couldn't find any services in Morocco. And my first option was to bring him to the US, but the insurance refused. So we sent him to France, where I did my grad school. And we found a place that we thought was good, but unfortunately, after spending a lot of money and spending a lot of time, he came back to Morocco empty-handed. And so I sponsored him, and you know, the story I told you before. Little Ghalia was injured in a car accident, and he spinal cord injury with her mom driving. So there was a lot of guilt in her mom's mind, as you can imagine. And she went to France, experienced that, didn't work, and then we were able to sponsor her. At that time, the MAIR clinic was not operational yet. This was in early 2014, late 2013, early 2014. And that was a miraculous recovery. You can see her after 6 months at Neuroworks. This is her first walking using a walker. You can see she's wobbly. It's a little hard for her to do, but she was able to do it. One of my favorite videos, because I was coming from Morocco, and when the airplane landed at Salt Lake City airport, I got the message that popped out on my phone. Please come to Neuroworks clinic ASAP. So I went straight from the airport to the clinic because I didn't know what was going on, and they surprised me with this beautiful walk. This is her at the MAIR clinic when we just opened. She transferred to the MAIR clinic from the Neuroworks, and you can see she's more stable in her walking. And this is using just crutches, a lot more stability and gait abilities compared to before. And she went back to school. She's actually top of her class. And if you believe her, she wants to be a physiatrist, a neurorehab doctor in the future. So what's the future plan? Future plan, this is what I call the dream, is to actually have a comprehensive medical facility, or I like to call it campus, with inpatients and outpatients rehab services, both for kids and adults. The one that we imagine would have huge impact on the Moroccan healthcare system, would be at 90,000 square feet therapy space, with the patient residential headquarters that you can see over here, and a staff of about 120, and the daily patient capacity of 500. This will be fully self-sustaining, meaning we don't have to worry about its operation cost. And the cost of establishing this campus is about $10 million. But this is far in the future. Like I told you, it's the dream. In the meantime, in the short term or midterm project that we have now, that we are working on right now, is to actually move, like I said before, to move the facility into a 20,000 square feet facility with the mostly outpatients, rehab services, but also some inpatients care, both again for pediatric and adults. We anticipate in 20,000 square feet, we can have a staff of 30 to 40 and have a daily patient capacity of about 120. This will allow the facility to be self-sustaining, so we don't have to worry about funding the operation on a daily basis. Before we found this facility, this property that I'm going to share with you, we considered several government-owned properties because they promised us to give us some kind of discount. But we quickly moved away from that because every time we considered a property, they were asking for bribes. And that's a huge issue over there. So we opted for looking for privately owned properties. And like I said, we found this one. It's about 10 acres, piece of land with pre-existing building. The building is about 10 to 11,000 square feet. And with some remodeling, I'm going to show you now, we can have it become about 20,000 square feet. The cost of this mid-sized property is about 1.8 million, and we raised so far $600,000. So this is just to show you the property map. It has a swimming pool. So it's a house, basically, it's a mansion, and it has a huge olive groves surrounding it. You can see that there isn't much of it because the property was not occupied for many years, and it has this main building, which is like I mentioned. So this is the entrance. This is me inspecting the property a year before COVID, and so the building is fairly good size. And this is the architect drawing. As you can see, like I said, it has a swimming pool outside. So we plan to knock out all the inner walls inside the building, make it wide open, and then build on this side over here, and then fuse the swimming pool after we transform it into a hydrotherapy facility. So this is the architectural plan of the building after remodeling. So downstairs will be adult rehab, next to it hydrotherapy, and then next to it some administrative space. And upstairs, we will build on the corner on the left side over here, and we will fuse everything, and it will be dedicated to pediatric neurorehab. The far corner with some beautiful terraces over there. There are some beautifully built suites or bedrooms. We didn't want to touch it because they were so nicely done. We are going to keep them the way they are, and then we will use them as a residential quarter for visiting U.S. medical professional in the future. Because even if the facility became self-sustaining financially, but also as far as the know-how, we plan to keep this relationship between the Mayo Clinic and the University of Utah, but also some other medical institutions long-term. So the last aspect I want to share with you is the one that I mentioned before. The grant that we got from Rori, the last one, the third one, is a part of it half of it will be dedicated to establishing the first neurorehab curriculum in Morocco. And this is going to be a 2 years graduate program. I call it graduate between parentheses because it's not the graduate program that we know as we know here. But it's going to be 2 years, 1 year for comprehensive theoretical education, and the second year for clinical training. And it will have a core component around comprehensive neurorehabilitations with several minor modules in general medical educations that has anything neuro connections in it, like in neurocardiology, neurourology, neuroradiology, neuro-oncology, neuroinfectious disease, and so forth. This is going to be done mainly in partnership with the University of Utah, School of Medicine, obviously, the University Hospital, the Craig Nielsen Neurorehab Hospital, the College of Health, Primary Children Hospital, as well as other medical institutions, both here and outside of our states, St. Mark Hospital, Craig Hospital in Denver, University of Louisville in Kentucky, UCSF, UCSD, and Boston College, just to name a few. Like I said, Rotary International is the funding party of this program, including 18 Rotary clubs here in the US, both in Utah and outside of Utah. We assembled already 20 teams of US medical professionals who committed their time between this coming summer and the end of mid 2025. And we hope the curriculum content will be accredited by the Moroccan authorities. And we envision possible sharing of this established curriculum with other countries in Africa. The one that we quickly identified are Senegal, Ivory Coast, Ghana, Nigeria, Mauritania, Algeria, and Tunisia. And I think that's all I have. Thanks for listening. Any questions?
Mo, I thought that was a wonderful presentation and so ambitious with your collaborations, both in the States and elsewhere.
Thanks,
I think, when you get this thing built, well, even now, to extend it to North African countries is going to be really huge, because motor traffic injuries, are just so common everywhere. And as you know already, there really isn't much hope for many, many people. There are resources in the urology rehab community. At least I know some of them in the region there,
okay,
especially in Senegal. So if and when you get to a point of wanting to engage with them, I can make some introductions.
Absolutely. I love that. Thank you.
Can you all hear me?
Yes.
Okay, great. Well, my video has stopped working. So a great talk.
You're breaking off.
Your audio is not working either, Sudha.
Okay.
Yes.
Well, in that case, Catherine, will you take over for me to moderate for questions?
Sure. So what questions do other people have? This is such an interesting aspect of the care that we all give, from basic trauma care on through all of the specialties. Neuro rehab touches on most of them, but we don't always think about that because as surgeons, we very often will hand off the patients once they're stabilized and not needing immediate surgery. And yet that's far from the end of the question. There's a lot of rehab that's critically necessary. So, Cody, since you are studying all of this now, where are you in your studies and what are you thinking?
So I'm a first year, just about to finish up my first year in a couple weeks. So studying for finals. I'm in the global health pathway elective too. But yeah, I thought this was a really interesting talk too. It's always interesting to see how like to manage such like a dire need and a low resource community. And so I really like your future plans and everything you were talking about, and like that like awesome utilization of the mansion to go from there. But yeah, I mean, this has been really cool for me to learn about, like, in my global health pathway, to see like how to utilize specific tools in specific communities. And I think that this talk shows you're doing an awesome job of that. So yeah, I'm excited to keep learning about global health. I think this stuff is so awesome, and especially within surgery, I think it's really cool and really needed. So yeah, I'm happy to be here.
Thank you.
That's my audio. Can you hear me?
Yes, we hear you now.
All right. Mo, my thoughts were twofold. One was, I'm sure that in the rehab field, there are lots of great tools to assess outcomes. I wonder if you could share a little bit about what that looks like. How do we assess outcomes? How you assess outcomes, rather? And then the second thing is, I loved your story about creating this machine there with $3,000. And so it makes me think, there's got to be ways to innovatively bring, I won't say bring, that's not the right word, create solutions that make sense in that environment, and especially now with the availability of technology, availability of internet. What are some ideas? What are some needs that where you could imagine innovation playing a role? Because that's another strength of the University of Utah and our partners. And it's people like all of us who understand the clinical needs, who can be the most adept in saying, here's what needs to be built that we can try out, as opposed to an engineer or a mechanic or somebody else who doesn't fully understand that clinical concept.
Yeah.
So those are my two questions.
Can you repeat your first question? I couldn't hear it
The
well.
first one is outcomes, and how do you look at outcomes? How do you look at it formally?
Okay.
And again, there's another opportunity there to innovate as well, because are there ways to capture that in a totally different way than is the standard in high income countries?
Yeah. So I'll start with your second question. So you are completely right. I mean, there is a lot of innovations that can be done very cheaply and very easily. That will be tremendous help to developing countries like Morocco. And I'm actually in the process of collaborating on 3 different projects, 2 with the mechanical engineering here at the University of Utah, and 1 with the bioengineering department here at the University of Utah too. And 1 project is focused on, so the locomotor training station that I told you we built in Morocco, it has a lot of high-tech features that we don't have in Morocco. And one of the most difficult things during that protocol is that for the therapists who are sitting on both sides of the patients, like I said, they have to trigger those sensory stimulations in a very specific and very coordinated way. And if you have a child, that's doesn't take a lot of effort and a lot of energy. But if you have an adult with the bulky and heavy legs, that process of delivering those sensory stimulations is really, really hard. So the product we are working on with the mechanical engineering is to actually develop a semi-robotic solution for that. So the whole process of sensory stimulation will be automated, and the therapist will only have to basically move the leg back and forth. And so we are making some progress in that. Like I said, so far it's really cheap, dirt cheap to make, and we filed for an RIRB applications, and we're waiting for the approval. And as soon as they give us the go ahead, we are going to try it here, both here on campus, but also in other medical facilities here in the Valley. Regarding outcome, one of the obviously there was a lot of challenges that I didn't want to share with you because you know, it's just typical stuff that you find in the developing countries. But the most of the pleasure and most of the gratitude that we felt, and what I personally felt, came from the fact that Morocco didn't have anything at the time when we started the Mayo Clinic. So no matter what we do, even if it's very tiny things, the impact of it was tremendous. And like I said, within 6 months of operations, we start having family bring in their cerebral palsy ridden kids from the dark, and then bring it to the clinic seeking treatment. And we get those relationship with the local medical communities, doctors that are sending us a referral that they never did in their life, because they didn't know that there was solutions to that particular neurological conditions. So we have a combinations of tools that we use to basically judge outcome. But the philosophy that we have in the Mayo Clinic is basically the one that we have here in the US, which is we don't give on anybody. We don't give false hope, but we don't give on anybody. And everybody who started the rehab, the Mayo Clinic, we just push them and then combine them until they reach the maximum recovery. If they reach a plateau, like we say here, and they are still not satisfied, we just change the therapy, increase the intensity or whatever we need to do to get them off that plateau and then progress more. So to answer your question in a nutshell, Sudha, we just outcome by how much we can do and how much is being done and how much the patient is willing to have as far as recovery is concerned.
Anna, you had your hand up, but we can't hear you.
Hello?
Yeah, I can hear
Now
you.
we hear you.
Yeah, perfect. Okay, great. I've got both a comment and a question. So first of all, I just want to say how much I appreciate the work you are doing with this. As someone who is the mother to a child with genetic epileptic encephalopathy, I can't believe I was able to say that all the way through, and a father-in-law with severe TBI that we're still dealing with to this day, it just does something to my heart. So thank you for the work that you're doing to help these patients. My question in specific was your curriculum content. You're establishing this neuro rehab curriculum in Morocco. Do you have a curriculum developer or like an educator specifically working with you on this? And if you don't, how are you going to ensure that your curriculum, your content, your teaching methods are educationally sound and effective?
Well, like I said in the beginning, the whole MAIR project is going to be based on the American model of doing things. So everything that we do in the Mayo Clinic is in English. All the therapists, before we hire them, they have to show English proficiency before we hire them. All the training that we have done with the help of University of Utah and some other institutions were done in English. All the documentations we are doing right now in the clinic as far as assessment, outcome, and follow-up, everything is done in English. So the teaching or the teacher are going to take care of this curriculum building, including myself, are people who actually are experienced teacher here in the in some kind of American institutions, and they are all volunteers. and everyone will volunteer to contribute to content that's related to their specialty or subspecialty. And we will basically, in the beginning, the first, this program that we're going to start later this year, we're going to, like we say in the popular expression, we will throw at it the kitchen sink and then see what
What
happens.
sticks?
Kitchen sink.
So as I understand it from what you've told me, Mo, and when we were talking with Paula Peterson, who does neurorehab at Primary Children's, correct me if I'm wrong, but I think you're planning to put together modules that can be scaled so that you can train new people throughout Morocco, but also in the region. Is that correct? Am I remembering that correctly?
Yes, and as far as the final design of this curriculum or the final content of this curriculum, we will only determine it after we execute this program that we received the grant for. As you know, Catherine, at the end of this program, we may recognize that some contents that are being proposed by some of our volunteers are probably too far ahead for the local needs, and we might trim it out for later expansion of the program. Does that make sense?
Sure. So you're planning to start with a sort of a simplified curriculum that's adapted to the needs and the capabilities of MAIR as it stands, and then to expand as you have the capacity to do that. Is that correct?
That's right, yes. So to answer your question, Anna, all of those contributors are going to bring content into this program are volunteers. They are professionals. Some of them are physiatrists, some of them are neurologists, some of them are cardiologists. A lot of them are going to be therapists with tremendous experience, whether it's speech therapy or physical therapy or occupational therapy or hydrotherapy or recreational therapy or whatever. And we will bring as many contributors as we can, and at the end of the program execution, we will see what works and what's can't work right now, but it might work later in the future, and so forth. Does that answer your question, Anna?
Yeah, yeah.
Mo, if I can jump in, as you develop these modules and curriculum, so the reason Anna was asking that question is she has a master's in education and specifically has helped develop curriculum for many of our fellowships. For example, we're newly starting a colorectal fellowship here and also contributing to a colorectal fellowship in Ghana. And there are multiple other fellowships. So that's the hat that she's wearing. But if something like that would be useful for you, and Cody was just messaging me saying, wow, this is such a great talk. Is there room for maybe somebody like Cody, one of our medical students, to work with you and your team to contribute to developing some of these modules? And maybe he can also work with Anna to kind of bring her expertise from the education standpoint, not from the, obviously none of these folks have expertise in physiatry, but education is a sort of a cross-disciplinary expertise. Right? So I think maybe that could be a cool way for us to support you further.
Absolutely. I would welcome Anna and Cody starting today.
That's fantastic.
I'm sorry.
Catherine, go ahead.
The other thing you had mentioned is that all of the staff and I guess future trainees at MAIR do speak English, but presumably many of the patients do not. So some of the materials that are given to patients, parents, and family for them to use at home will probably need some translation or something so that they can both understand and also work on aspects of the care themselves. So do you have a plan for translation of this curriculum?
Yes, we actually did that. We started doing that during the training that we have done since 2014. I'll give you an example. For instance, with cerebral palsy, as you know very well, Catherine, one of the deadliest aspect of these conditions is swallowing issues.
Yes.
And then we actually lost a kid because of aspiration pneumonia, and despite our advice and then follow up with the mom, she just didn't do a good job. At some point, he had a severe fever, and she didn't communicate, and the next thing we know, he passed away. So feed-in therapy was actually one of the first things that we focused on because of the urgency of the situation over there. And the first team that did that was actually from Boston College. And when they came in, we translated some of their brochures and then materials into Arabic and French, and added some schematic presentations, because a lot of some of the women, they cannot read. And so we did that. We started doing that a few years ago. And then you're right, some translations will need to be done, especially for the purpose of home therapy or follow-ups at home. And we have done some of it, so we have some experience.
Mm. We also have some in-house resources with Anna.
Okay. Awesome. Anna and Kudi, when you guys want to grab lunch?
Can definitely send you an email. And I don't know if it's how useful it'll be for Morocco, but I do speak Iraqi, and I know it's like completely different from Moroccan Arabic, but I can help with that aspect too, if you want.
We'll take that.
That's an amazing talk. Oh, very, very inspirational. It's so exciting, and I feel so humbled to hear about this work, especially as a trauma surgeon. Like, I know a lot of my patients need this support, and I have so little expertise in it, that, as you're describing it, it reminded me how little I know and how much our work is really collaborative in taking care of patients.
Yes.
So thank you so much. And I'll maybe connect the three of you all, you, Anna, and Cody, to work out, see if there's some opportunities to work on some small things. And
Yes.
Anna and I hope Cody can get his feet wet, and then see if there are opportunities to contribute, especially if you've got teams going already for the next 2 years. My goodness.
Yes.
I think that's phenomenal.
We still have a spot for you, Sudha.
I actually was just thinking that I met one of the heads of rehab in Rwanda when I was there last month, because he was meeting with we were all meeting with the representatives from the American College of Surgeons, and so I was thinking about sending him a message and seeing if there's a way to connect the two of you. I think that would be, so anyway.
Yes, absolutely.
I'm going to turn back to Dr. DeVries, who's been moderating the last comment.
I'm not sure I have much more to say, except that it's just astonishing what you've been able to do in a very short time, not just with the building, but also with the rounding up of resources. That's not a trivial aspect to any kind of facility building, curriculum building, training of staff, looking for resources, finding that with Rotary, that is a skill in itself that most of us in medicine don't learn. We don't learn how to raise money. And you do have to learn that because, these are not going to be NIH grants. These are going to be largely private philanthropy. Where you look for that, how you pitch your case, how you engage people, how you tell the story. And I think your story is very effective. The examples you gave with the children, especially so, because those pull the heartstrings, and that also pulls out the wallet. So I think that these are real lessons for those of us who want to do sustainable work, that we need multiple sources of funding. But the idea that you've presented, that this will become self-sustaining with a mix of paying and non-paying patients, I think is particularly compelling, because it has to long-term be able to hold its own in Morocco and anywhere else you set it up. So it can't be, a long-term charity thing if you want to have it be basically owned by the Moroccan people.
Yes.
So this is a really good aspect of what you've presented that we don't always hear.
Thank you.
So I think we've come up to the time.
Hafsa has a question, I think.
Yeah. Oh, sorry, Hafsa.
Oh, no, you're fine. If we are out of time, I'm fine. That's okay. I just
No, I
wanted
think
to.
you've got time for yours.
Okay, I just wanted to comment along the same lines, Dr. Gaston, you mentioned about the funding and stuff. So my question was actually that, how do you know which organizations to reach? Like, is there a specific, you research for those organizations? Or how does that work? And it is very inspirational project. And me being from Pakistan, I always think, how can I do some kind of work in Pakistan? And I have no know-how of those things, but it is very motivating. So thank you, first of all.
Well, trust me, when I started the charity, I had no clue what to do and how to do it. And I just got blessed by a lot of people here on campus who gave me advice. And I just followed up those leads, and I kept working on them for many years. Rotary, it took me about 4 years from the day we met the first time. It took about 4 years for them to give us the first $5,000 grant. So persistence and hard work obviously is a basis for a lot of things in life, including fundraising. Some of the opportunities that I had, especially with the Sorensen Legacy Foundation, it was completely serendipitous. I used to run with a good friend of mine who works for the Utah government. He's a high-ranking guy, and we used to do marathons. And 1 year in 2010, the president of Senegal was in town, and they were hosting him for lunch. And then he was they were trying to see who is in Africa that can attend this meeting. And then France thought of me, and I attended a meeting. And during that meeting, I met the CEO of the Sorensen companies here in the Valley. And we end up meeting in his office, and told him about my expertise. And they were trying to develop a kit, genomic DNA analysis kit. And I had done some work in the past, and gave him a couple of ideas. It worked. And he reinvited me to meet with his staff and at his company. And at the end of the discussion, he says, I want to learn more about what you do. Tell me more. And in the middle of the discussion, I mentioned this project, which was not existent at the beginning. It was just the thought. And he says, did you know that the Sorensen family has a foundation? I told him, no, I didn't know. And he says, well, I'll introduce you to them. So that's how it all started. So you really have to just try everything that come your way and be persistent about pursuing them. And one door opens up and it opens up other doors and so forth. So
I think that's
Thank
a
you.
beautiful response, and that has been my experience with nonprofits also. But also considering that the University of Utah is also a nonprofit, it also applies to the Center for Global Surgery. So in many different ways, both persistence and serendipity, these things work, and that's a beautiful example, Mo.
yeah, thank
I
you.
think it's probably time to wrap it up for today. And thanks so much for sharing with us your experiences and for everyone who's joined.
Thank you all for listening. It was a pleasure. See you next
Take
time.
care.
Thank
Bye-bye.
Thank you so much.
Thank you. Bye-bye.